Last but certainly not least, we're going to hear from Dr. Emily Wenzel, Associate Professor of Anthropology and Director of the International Studies Program at the University of Iowa. Dr. Wenzel is a medical anthropologist who studies the relationships between changing gender norms and new sexual health interventions. She'll be presenting on how to support sexual health without stereotypes.
Hello, I'm Emily Wenzel. I'm an associate professor of medical anthropology at the University of Iowa, and I'll be discussing how we can support sexual health without stereotyping. So I said I'm an anthropologist, but what is that? What is anthropology? And also, why should you care? What we do as anthropologists is we study people across time and place. And that actually is so broad as to be useless, right? So what makes us anthropologists is that we study people in a particular way. Some of the key aspects of what we do are that we look comparatively at people across culture and place. So how do people do or experience life differently in different contexts? We also take a holistic approach to human behavior and human bodies. So, for example, as is relevant for medical professionals, we see culture and biology as developing together, not separately. Finally, we really try to understand people's differences across time and place without using ethnocentrism. Ethnocentrism is the practice of judging other people really by your own cultural yardstick, thinking, well, because I do something, that's the right or best or normal or natural way to do something. I want to stress that this isn't a moral position. It's not to say anthropologists think, whatever you want to do is okay. It's to say that in order to actually make good moral judgments or any other kind of evaluation, you first have to understand why people are doing what they're doing in a holistic kind of perspective. So I'm a medical anthropologist, and that is applying these fundamental principles of anthropology to the anthropology of health, healthcare, and embodiment. By embodiment, I mean both our experiences of what it's like to have a body shaped by our context and the very physical body itself. Talking about medical anthropology with healthcare practitioners, I think practitioners often find really useful because it gives you tools to analyze healthcare practices as cultural practices, to understand the world of healthcare in which you work as its own subculture with its own practices, norms, values, constraints. Especially we can understand how medical cultures interact with structural contexts. And for example, later I'll talk about how the time you have to talk to a patient matters for what you can say. Another reason medical anthropology can be really useful for thinking about health and bodies is because using comparative, holistic, and anti-ethnocentric approaches, we can denaturalize our assumptions about what's natural, normal, and universal. And by denaturalize, I mean just what it sounds like, to take what we might assume is natural with all the value judgments associated with that and realize, oh, no, this is actually a norm in a specific time and place and context. And that really matters when we think about sexuality in healthcare practice, as I'll discuss. So what I do as a medical anthropologist, just to give you some more context for who I am, is I teach classes at the university and I also do research. My research looks at how men and couples incorporate emerging sexual health treatments and experiences into their changing ways of being men, of being spouses, of having a marriage and a family. So for example, here's a book I wrote called Maturing Masculinities, in which I talked with aging Mexican men in the city of Cuernavaca about their experiences of decreased erectile function over time and found that most of them did not want EJ drugs like Viagra because ideals about what it was to be a good man had changed over time, from focusing on having sex with a lot of people to focusing on like faithful emotional support for one's wife and children. So they were able to change over time according with gender ideologies by incorporating that bodily change into stopping focus on penetrative sex outside marriage and focusing on emotional relationships within the family. So in the U.S. context that we're here to talk about today, what are some relevant things that we know about sex? In the U.S., as you well know, sex is simultaneously a taboo. We think, oh, we can't talk about this. It's a sensitive subject. And it's also a cultural obsession. Pretty much all we talk about, if you listen to like any song in the radio, is sex. We talk about sex all the time, and we talk about how it's taboo all the time. we have many stereotypes and also many different norms regarding sex and sexuality. These include gendered stereotypes, right? Assumptions that men all want a certain kind of sexuality. Often stereotypes about women as not being as sexual, right? So there are all sorts of gendered stereotypes. For example, we also have age-based stereotypes about sexuality. Young people are sex-obsessed. Old people don't want sex. All these things are true in some cases and radically untrue in others. But these are sort of the guiding stereotypes that in our culture we acknowledge as normative. There's also a really diverse range of sexual practices that people engage in the U.S. Some of these are seen as normative or even valued, right? Procreative heterosexual sex is seen as somewhat compulsory. It's a thing that people are supposed to engage in our culture. Some kinds of practices are stigmatized, right? Practices like S&M, for example, are seen as somewhat taboo, although, as I said before, also titillating and a big topic of conversation. I think what's most important to think about when we think about sexuality and norms is that individual people's desires also can vary, right? They can vary in accordance with a person's stage of life, their state of health, the relationships they're having, the ideologies they've been exposed to, what social circles they're traveling in at a particular time. So there's a lot of diversity. I think diversity is the rule when we talk about sexual practice. However, another thing we know is that given the partly taboo nature of sexuality, sexual health care has been totally siloed and in many ways silenced. There's really little space in healthcare devoted to sexual function. It's often limited, for example, to people who focus on genitals specifically. And even less talk in medical education, healthcare education, is devoted to pleasure, right? So we might talk about function, for example, can you get an erection? But we rarely are taught to talk about the things you want to do, what makes a sensation pleasurable or not pleasurable. And providers might get little or no training in sexual reproductive health at all, if that's not their specialty, and particularly in conversations about these things like sexual pleasure. It also can be hard to have these conversations, even for people and providers who really want to, because of the structural context of American healthcare, right? Your workload is very high. You're sort of pushed to schedule as many patients as you can, right? You often, if you're a nurse on shift, might be caring for many patients at one time. So our workload and scheduling pressures really reduce the opportunities to talk with patients about this aspect of life, where often people sort of want to get a conversational warm-up or get to know someone before broaching topics related to sexuality. So all that makes it very hard to talk about sex in medical practice and healthcare practice. What makes it in many ways even harder or more frustrating when you're thinking anthropologically about trying to reduce the use of stereotypes is that the sexual health interventions that do exist and are widely promoted and widely advertised, often pharmaceutical interventions, can actually promote stereotypes about sexuality and things like gender and age. A key example of this, and as I said, one thing I've researched, is treatment for erectile dysfunction. Erectile dysfunction is defined medically as the inability to attain or maintain penile erection sufficient for or satisfactory sexual intercourse. You can see I've underlined the words sufficient and satisfactory because these really get erased in things like Viagra marketing, right? Often in terms of scales that measure erectile dysfunction, for quantitative research on the topic also, right? We tend to look at how much erection can a man get, things like rigidity and frequency, and not to ask those questions that an anthropologist would argue are even more important, right? Is it sufficient for the kind of sex you want to be having? Is it sufficient for that satisfactory intercourse? So what ends up happening is that focus on just the presence or absence of erection, not the pleasure aspect or the interpersonal relationship aspect, reflects gender assumptions about masculinity, right? This assumption that, well, of course men want to have penetrative sex. So of course they all want to have these erections needed for penetrative sex. Any man and anyone who's had relationships with men can say, well, that's not always true, right? What if partners are having a fight? What if the man is asexual, right? What if he just is in ill health and is in the mood for that? Or what if his partner wants to do other things that he's equally interested in? So this, I think, is a clear way that gender stereotypes of masculinity have shaped medical practice in these very narrow ways that then serve to reproduce and naturalize, make to seem biologically natural, cultural assumptions about men and erections. So marketing has been a big part of this. So let's take a minute to analyze an ad. So this is an ad from a Cialis campaign a few years ago. And I'm sure you've seen these ads on TV for Cialis, Viagra, Levitra, all those erectile dysfunction drugs. So take a moment. The presenter can pause after I explain what to do. And just jot down all the norms and assumptions you notice here in this ad. Norms about sexual desire, about life, about how to be a person and partner. So take a moment and just write down what you think this ad is telling viewers about how men should be and how people should be. Okay. So, if I was doing this in person, I would ask you what you had thought. I wish I was there. But what I assume you might have said was that this ad is making some statements about who it thinks men are, who it's selling that men are, that Cialis is here, right? That even though these people aren't having sex, that the need to have penetrative sex is what binds them together. So it's saying that men always want to engage in penetrative sex, so do heterosexual women. It's also implicitly saying, right, that to maintain successful heterosexual marriage and love, there needs to be penetrative sex. And also it's saying to have the good life, you need to have penetrative sex, right? There are sort of implicit messages about class status. I don't know if you've ever been to a fantastic bathtub spa overlooking the ocean. I never have. I think that's above my pay grade. So there's a lot of cultural baggage packed in here in an ad selling a medicine to give men more firm erections. So these are problems, I would say, because this is a part of our culture, just one piece of a broader cultural message about norms for masculinity and male sexuality, saying that men must sexually penetrate to be healthy and normal, right? And it's problematically framing that cultural norm as a medical fact, right? When we change that actually quite subtle definition of what is erectile dysfunction, you need satisfactory and sufficient erection. It's saying no, like that a man can penetrate is normal, is normative, is healthy. And so what that does by casting lifelong unceasing penetrative sex with firm erection as healthy and normal, the flip side of that is that it casts what is really common diversity in sexual desire, that people might not want that, and that people might want different things over time. It casts that as abnormal and as unhealthy. So we have a problem, right? That under the guise of sexual health, we might accidentally be promoting gender stereotypes, sexual norms that don't really help our society or help patients feel better necessarily if they don't want those things. So what do? Lack of discussion or treatment is not the answer, right? To clam up about these things creates its own problems because sexual side effects of medical treatments and of medical conditions can really cause great suffering, right? Some people really do want to have penetrative sex, and it's important to their gendered sense of who they are, and it's important to their relationships. We see what happens when we don't talk about sexual problems with really pretty much the entire experiences of being a woman and getting health care, right? Vulvar pain is famously dismissed as, oh, it's all in your head. Or as, yeah, that pain is there, but, you need to have sex, and so it's just something to sort of grin and bear it or power through. Any woman who's had a child and at 6 weeks is just told, okay, yeah, you're cleared to have sex, and thought, ow, right? This just sort of illustrates how much women's pleasure in sex, and also men's pleasure, as I've just said, with the normativizing of erections, isn't really a focus. So what can we do? What can we do that is talking about sex in healthcare, but that is not reproducing problematic stereotypes and assumptions? Put otherwise, how do we support sexual health without naturalizing cultural stereotypes, right? Without making our own cultural ideologies seem biologically natural. And then without that flip side of framing particular acts as normal and others as abnormal. going to tell you seems blindingly obvious and simple. And the truth is that simple can be hard, right? What we do is we talk. But, and this is the hard part, we talk without ethnocentrism. So earlier I defined ethnocentrism as judging other people's cultures by your own experience and yardstick. So in talking about sexuality, what we need to do is discuss other people's experiences without casting our own as the norm, without universalizing our own experience, assumptions, or those of our culture. So here's how I would suggest going about talking about sexuality with patients. First of all, to do it, right? Which is the whole point of this conference. Even if you haven't been trained to do it, because you probably haven't, whenever there's a disease or condition or a treatment that can have sexual side effects, it's very important to explain that. And I would say to explain them all, right? Noting that some of what you're going to say, none of it or all of it might be relevant. And that ensures you're covering the necessary bases, right? If you look at a patient and just based on what they've told you or what you see and you assume, oh, they probably do X, Y, and Z acts, or they don't enjoy A, B, and C acts, that's when stereotyping can come into play. So you can just say, well, here is the treatment you're going to have. Here are all the kinds of things that it can cause in terms of sexual health and function. Another way to do that is to really avoid assumptions not only in content, but also in language. So this is a learned skill, but really make the effort to use non-gendered and non-normative language, right? So even if you're dealing with a patient who is identifying as a woman and she's married to someone who seems like her husband, they might be polyamorous. She might have a secret sex life from the husband. You don't know. So always refer to people's partners, right? Instead of husband, wife, whatever partners you've seen. And you can do that in a way that doesn't imply that they have multiple partners, because again, some people who are monogamous might be offended by that. But you can just say in a more detached way, right? Like, people undergoing this treatment should talk to partners about whatever thing. Talk about people's particular parts and functions and how they might change, rather than making assumptions about what might matter, right? So for example, anyone who has an anus might enjoy penetration regardless of their sexuality. So if a treatment or a condition is going to affect their enjoyment of or ability to undergo anal penetration, that's a thing to tell them. It's also important, I think, to note to the patient when you're talking about sex and sexuality, to note that people engage in a whole lot of different acts, some of which don't involve the things we tend to see as standard and normative in American culture. Penetration, for example. It's also important to be explicit about the fact that you know that people's desires change, often in relationship to age, to what's going on with their relationships, to their context, but also just, people change over time. So I think that can be helpful in talking about all the bodily things that can happen, because it's not saying, oh, I can tell you like ABC things, so here's what's going to happen. It's saying, hey, people during their lives engage in a lot of different sexual practices, so I'm going to tell you all the different things that might happen. Some will be relevant, some won't. After that part of the conversation, you really just ask. And this is a thing medical practitioners are really experienced at, right? Taking medical histories, asking about symptoms. Just ask what they want to know more about and give them that space to answer. So interpersonally, how do you do this, right? That is simple but not easy. You as a health practitioner have already developed a clinical voice for dealing with tricky issues, right? In your line of work, you're having to talk about difficult things all the time. And I'm sure you've really developed that tone of sort of detached caring, right? That I'm calm, I'm confident, I'm here for you, here's the information. Use that same tone, right? If a patient or their partner, someone in the room, is uncomfortable or says that they're uncomfortable, it's okay to acknowledge that, right? It's okay to say, yeah, talking about sex is often seen as pretty taboo and it makes people uncomfortable. Do you want to continue this conversation? Do you want to not talk about this? They might not. That's okay. But often just acknowledging discomfort on the patient end can really facilitate things. On your end, you just want to be that calm provider. if you're attending this conference, I'm pretty confident that you have the skills and mindset needed to do this. And sometimes it just helps to get a reminder to use the skills you develop for other kinds of communication with patients in this arena. It can help to just be reminded to use that non-gendered language to avoid those kinds of assumptions, to denaturalize your own assumptions about what's sort of healthy and normal and typical in terms of sexuality. But I'm confident that you all have the skills to do this simple but not easy task. So that's all I have for you today. I'm looking forward to actually interacting with you during the question and answer session. So hopefully I'll now appear in person. Thanks so much. Bye-bye.
Thank you so much, Dr. Wenzel. I think you and I met maybe 2 years ago at this point, and you were asking for my opinion on building a men's health program. And it was during our time when we met together that I realized you are perhaps the most important person on my team. The work that you do as a medical anthropologist is how people even show up in my office, and perhaps why most people never show up in an office like mine or an office like Dr. Coulter's or any of us who actually treat sexual dysfunction. And so if we want to get those people in, we must understand those cultural norms, from your perspective. So we have a few questions for you. The first question is, what are other examples of sexual health issues that people might experience?
Also, thank you for saying I'm important. I appreciate that. I think I could expand a bit on the issue of vulvar pain or vulvodynia that I brought up briefly. I focus mostly on men's issues in the talk because that's my sort of focus in my work. But I think they're interesting mirrors of each other, because men are often given this message: you have to have erections or there's something wrong with you. And women are often told painful sex is normal. That also really intersects with inequalities of age and inequalities of race that you've heard about earlier, right? So older women often experience things like vaginal dryness just in the course of change over time, menopause. Often there are not good discussions around that, including basic non-medical solutions like lubricants. But often also Black women, particularly and women of color, are expected to put up with pain in general, but also in terms of vulvar pain, sexual pain. So I think the earlier call to focus on implicit bias is also really relevant here, to think about what biases we might have about sexual norms and stereotypes, but also how they interact with expectations and implicit biases about gender, age, and race. And so always coming from that questioning perspective, I think, rather than the assuming perspective is really helpful with that.
Yeah, and then I wanted to make another comment. You had mentioned, that definition of erectile dysfunction, which we see all the time as urologists, and you underline that satisfactory, word. And it just got me thinking, a guy can have an orgasm without an erection, and he can also have an erection without an orgasm. And I see people kind of all along those spectrums, and I see happy and also frustrated patients anywhere along those spectrums. So just so many assumptions that we make in our healthcare system. My next question is, what are your experiences talking to people about their sexual health experiences?
So I think my work as an anthropologist can be instructive for healthcare providers looking to have these potentially scary conversations, because what I do for a job is I show up, usually in a different country from my country of origin, and ask strangers intensely intimate questions about their sex lives and their medical lives. What has constantly surprised me is how many people are desperately wanting to talk. For example, in the book I showed, in that study of older Mexican men's experiences with decreased erectile function, it was very hard to get grant funding. People said, no one will talk to you. People don't want to talk about it. I thought maybe 25 men would talk to me. I stopped the study after over 250 men agreed to talk, because every single person I invited wanted to talk. And people would say it's like unburdening yourself. It's like therapy. People would ask to bring their wife in to talk together. So I have found overwhelmingly in my research career that if you care, if you're willing to listen, and not that you show some particular knowledge or expertise, right? Not that you're there to tell them something, but really that you're there to listen and practice that cultural humility we heard about earlier. Most people want to talk. So I think being an anthropologist shows that All you have to do is ask and listen actively. And a lot of times that gets everything going, and that's all you need to do.
Thank you, Dr. Wenzel, and thanks for helping us wrap up our day. We appreciate your time.